Hi everyone, my name is Christine. I currently work in the Infection Prevention and Control Department of a tertiary hospital in Melbourne. For today's Journal Club session, I will be critiquing an article titled Vascular Access Specialist Teams versus Standard Practice for Catheter Insertion and Prevention of Failure, a Systematic Review. The aim of this study is to compare the effectiveness of a vascular access specialist team, which I will be referring to as VAST, versus standard practice in relation to cannulation success and maintenance in hospitalized adult inpatients. Based on the information provided in this article, standard practice is defined as the usual care provided by nurses or doctors who are not part of a specialized vascular access team. Comparingly, the VAST described in this systematic review consists of a multidisciplinary group of healthcare workers who have advanced competencies in the insertion, evaluation, care and management of vascular access devices. So what has been done before? Previous research completed by Savage et al. Found that an implementation of a dedicated vascular access team at a 300-bed care centre led to a significant reduction in central line use, as well as a reduction in central line associated bloodstream infections. Another study by Quinn et al. Emphasized that VASTs play a crucial role in selecting appropriate catheter sizes for patients, particularly in high-risk cases where vein access was deemed challenging. So why is this relevant to infection control? The role of infection prevention and control in healthcare settings is to prevent and reduce the risk of healthcare-associated infections. Peripheral intravenous catheters, which I'll be referring to as PIVCs, continue to represent a number of healthcare-associated Staphylococcus aureus bacteremia infections, also known as SABs. According to a study performed by Rhodes et al., 35% of hospital-acquired SABs were directly related to PIVCs. By implementing a vascular access specialized team into the hospital setting, the rate of successful insertion access within 3 attempts increased from 89.4% to 95.6%. To summarize, the systematic review investigated the effectiveness of VAST compared to standard care practice to determine cannulation success and assess the maintenance of vascular access in hospitalized adults. The research focused on extracting and analyzing numerical data, such as the cannulation success rates, incidence of catheter-related complications, and patient satisfaction scores. So the research question is, in hospitalized adults requiring vascular access, how do vascular access specialist teams compare to standard practice in terms of cannulation success and the maintenance of vascular access, also including the reduction of peripheral vascular complications? The population intervention comparison outcome, also known as PICO framework, has been utilized to formulate the above research question. The research question is important because vascular access is a critical component of care for hospitalized adults. According to Cook et al., about 60% of hospital inpatients require a PIVC during their stay, with the number increasing to 90% for patients admitted to the emergency department. Successful cannulation is essential to delivering effective intravenous treatment, although challenges often arise that hinder successful cannulation, particularly in patients who are older, obese, have no palpable or visible veins, or have a history of difficult vein access. Vascular access specialist teams are designed to address these challenges by providing specialized expertise in the evaluation, insertion, and maintenance of VATs. By comparing the effectiveness of VATs with standard care practices, the research question seeks to determine whether the specialized approach offered by VATs leads to better patient outcomes. Additionally, this paper has the potential to influence the economic burden on healthcare systems through minimizing PIVC complications, leading to shorter hospital stays. So the paper was conducted as a systematic review adhering to a protocol registered with Prospero. Several electronic databases were searched. These included Cochrane Library, Medline, Web of Science, Scopus, and EBSCO Host. Additionally, the main clinical trial registries, including the Cochrane Central Register of Controlled Trials, clinicaltrials.gov, and the EU Clinical Trials Register were also searched. Two researchers independently conducted a structured data search in April 2021 and compared their studies for their results for validity. A third researcher replicated the search in May 2023, and the results were reviewed in a team meeting to ensure accuracy. The search strategy was developed based on the PICO framework and was piloted before the full review. Search terms were combined using and, or, and not operators to refine the search. The search covered studies up to May 2023 with no restrictions on the date of publication. Studies used were limited to those published in English or Spanish and only included adult inpatients. For the inclusion criteria, randomized, non-randomized, and observational studies were used that compared the activities of VAS with standard clinical practice by doctors or nurses. Studies focused on adult inpatients requiring VAD insertion and maintenance were eligible. For the exclusion criteria, studies focused on pediatric patients, vascular access for hemodialysis, arterial catheters or centrally inserted catheters were excluded. Review papers, expert opinions, and qualitative studies were also eliminated. Data was independently extracted by two researchers and compiled into Excel tables. Extracted data included study design, objectives, outcomes, team composition, patient population, and setting. The main outcomes analysed included cannulation success, catheter failure, adverse events, for example phlebitis and infection, and patient satisfaction. Due to the heterogeneity of the included studies, a narrative synthesis was conducted where results were presented descriptively instead of a meta-analysis. The 2018 Mixed Methods Appraisal Tool was used to assess the methodology of the included studies. The studies were assessed for bias in sample representativeness, outcome evaluation, and control of confounding factors, with most found to have a high risk of bias. For the critical analysis, the Joanna Briggs Institute Critical Appraisal Checklist is utilized. First, the research strategy was found to be well designed and comprehensive. The authors conducted a structured search across multiple major databases. The search terms were based on the PICO framework, ensuring that the search was relevant to the review's objectives. Additionally, the search was replicated by multiple researchers to ensure validity. The Mixed Methods Appraisal Tool was used to appraise the studies. This tool was highly appropriate, given the diversity of study designs in the review. The process of critical appraisal was conducted with a high level of rigor. 4 researchers independently assessed the quality of the included studies using the MMAT, and any discrepancies were resolved through group discussions. This approach minimized bias and ensured a balanced evaluation. The review did not explicitly assess publication bias using specific statistical methods. However, the comprehensive search strategy, which included both published and unpublished studies, suggests that the authors took significant steps to minimize publication bias. Limitations of this review include significant differences in the composition, availability, functions, and target populations of the VAS examined. These variations make it challenging to analyze the data collectively. This review also lacks long-term consideration, only focusing on immediate and short-term results. The study also did not sufficiently address the differences in patient populations and cohorted the patients as adult patients. Age, morbidity, and severity of illness may impact the effectiveness of VAS. Furthermore, only studies published in English were included. This exclusion could result in language bias, potentially neglecting relevant studies published in other languages. The review did, however, offer clear directives for future research. The authors highlighted the need for further clinical trials to evaluate the efficacy of VAS, across different contexts and stressed the importance of assessing the cost-effectiveness of these teams. The bibliographic search yielded 3,053 titles, with an additional 24 studies identified through direct search methods. After the study selection process, 12 published reports were included in this review, encompassing a total sample of 5,213 patients and 54,152 catheters. Most of the selected studies evaluated medical teams dedicated to cannulation and/or the administration of intravenous therapy, with publications spanning from 1984 to 2021. Among these, 5 studies were observational and only 2 were randomized controlled trials. All the studies were published in English. In 11 out of 12 studies, the teams were either assumed to be or were exclusively dedicated to the primary insertion of VADs, often for patients with difficult intravenous access, or those with specific needs. In other instances, the teams specialized in specific insertion techniques, with 6 teams focusing on PIVC and 2 on peripherally inserted central catheters. Some teams also engaged in maintenance activities, conducted training programs, or managed quality control processes. 8 out of the 12 studies were found to be at high risk of bias. 5 of these studies were non-randomized trials, suggesting that the allocation of patients could have been influenced by other factors. The studies also reported a wide range of success rates from 80% to 100%, indicating potential variability in study populations, techniques used, or practitioner skill levels. Overall, individual studies suggest that implementing VAS can lead to a reduction in catheter-associated adverse events, particularly phlebitis and catheter-associated infections. 4 studies reported a reduction in PIVC-related phlebitis, while 3 studies documented a significant decrease in catheter-related bloodstream infections. Cannulation success rates ranged from 90 to 100%, with 1 study assessing this variable in non-VAS patients, showing an 80% success rate. First attempt success rates varied from 81% to 98%. As the studies involved in this review focused on hospitalized adults, often with specific needs such as having difficult IV access, this does not represent all hospital populations. Patients in outpatient settings or those with less specific needs are excluded, as well as any patients not considered an adult. Furthermore, most of the studies were conducted in North America, where healthcare systems, training, and resources might differ significantly from those in other regions. This limits the generalizability to hospitals with different healthcare structures. The outcomes reported across studies were varied and sometimes not directly comparable. This makes it difficult to draw consistent conclusions that could be applied across different populations in healthcare settings. The findings of the systematic review are highly relevant to journal club participants, particularly because the review emphasizes the critical role of VAS in reducing catheter-related infections, a persistent challenge in infection control. By discussing the effectiveness of specialized teams like VAS, participants can explore how teams can lower the incidence of catheter-related infections. Additionally, since phlebitis is a common and serious complication of PIVCs, understanding how VAS can help reduce these issues can offer insights into strategies for improving patient outcomes. While the systematic review provides meaningful observations into the potential benefits of VAS, the applicability to a wider population is limited by the specialized nature of the study population, as well as the variability in team practices. Therefore, while the findings suggest that VAS can improve patient outcomes in hospital settings, caution should be taken when generalizing these results to other populations. Additional high-quality randomized control trials in diverse healthcare settings are needed to validate these findings and better assess the broader applicability of VAS. Thank you for listening. Here are my references.